The payers initially will manage these like they manage all other drugs, which is that they'll pay for them grudgingly. Um, they'll manage them in any way that they have at their access. Um, it's funny, I just recently completed a project where spoke to a number of payers about step therapy in Medicare Advantage plans. As you know, Medicare Advantage plans were empowered to exercise step therapy, even across benefits, so including medical injectables. Um, they're hesitant to do that. They are. Um, People laugh at me when I say this, but it's true. Payers hate disruption. They don't want to make their beneficiaries angry. They don't want to make doctors angry. That makes more work for them. And they don't want to get it wrong. They don't want to hurt people, and that's good. So we haven't seen much of that, but the more drugs you have in a class, the more the drugs look the same, the more tempting it is to go after that. We're seeing that now, of course, in biosimilars. In biosimilars, I think payers have largely come to the conclusion that the regulatory universe, the regulatory pathways for biosimilar approval are good, and they can trust the FDA in this. They also have the advantage that this has been going on in Europe for a decade, and there's been no ill effects, so they've got a little bit of a track record to go on. But they haven't done it in other either supportive or, more importantly, therapeutic classes. So we'll see how that plays out. I expect that to happen. I can't imagine, and I know I drive some people crazy when I say this, that they won't do that, for example, in the PDL space, PD-1 space. In the PD-1 space, there's a lot of drugs. The FDA-labeled indications overlap a great deal, not uniformly. And so it's tempting to think about how payers might manage IO therapy, which is quite expensive. Very effective, but quite expensive. So we'll see what happens. I don't think we're going to have to wait very long. I think we're going to see things in the next year or two. There have been a number of articles written about how challenging it is for physicians to manage the rapid developments in the space. One approach, I think, has been for the specialization of oncologists, even in the community setting, much as already occurs in the academic setting. Pathways actually help a lot because they operationalize, for example, guidelines. But I don't know that I have a great answer for this question. I think that this is going to continue to be a challenge. I think as we, for example, get more and more molecular testing and therapy guided by somatic mutation analysis, it gets even harder. We're at in the infancy of that. We're using monotherapy, one drug, one mutation, but that can't be how this goes. This is going to wind up being combinations inhibiting multiple pathways. So we will continue to be challenged by this. I think actually technology may be the key to solving this. As you may know, I worked at Flatiron for a while, and we had these sessions where we just kind of ideate. And I told one of my friends there that my vision of how an oncologist is going to manage their patient is sort of it's not exactly like Watson on Jeopardy, but it's not terribly different. So what we'd like to do is provide the physician at point of care with the appropriate, quote, appropriate treatment options in a probabilistic format, because that's how people make decisions, right? It's very rarely binary, black and white. This is going to work, it's not going to work. More likely it is, well, we think there's about a 35% chance it's going to work. And we want to somehow pull in what my friend Amy Abernathy was always interested in, which is a rapid learning system. Every patient that we we learn from. It feeds back into the system, and that real world evidence continues. So when you're seeing that patient, and you have that critical clinical information, the critical genotypic information, it's all in the machine, and it spits out information for you. And your job as a physician is to interpret that in the context of the patient's needs and desires, because the machine can never capture that, but true shared decision making will. So that now that's not going to happen anytime soon, but ideally that will ultimately be what happens. And then the question about whether or not you can keep up with all the publications, which I think most people cannot right now, and it's not going to get any easier, becomes a little bit less important, because there'll be a repository of knowledge that can be presented at point of care that will help you take care of patients.